tons of data in GI and gastric and G junction cancers and esophageal cancers, is a still an unmet need. Matterhorn is a big step, but there's a lot more work to do. Like we want to cure more patients. There's a lot of new targets, new drugs, and some of the highlights we saw at ASCO, um, like we saw the first positive CAR T cell trial in solid tumors ever, and it was a Claudin 18.2 CAR T in gastric cancer, beat chemotherapy. We saw um, phase 3 Destiny Gastric '04, which basically solidified the idea of giving TDXD in the second line as probably the preferred strategy for HER2 positive patients. We saw follow-up data from Checkmate 577. We saw a lot of things. We even outside of upper GI, we saw a lot of data in colorectal. More evidence to support roles for immunotherapy, particularly in these MSI populations. So it was a big year for GI overall. A lot of things probably didn't have time to cover, but we expect a lot more. I mean, there's some really highly anticipated studies in upper GI in the near future, like the FGFR2 trials. We have these two big phase 3 trials that we've been waiting to see. Dante, which is another big perioperative trial. Hopefully, will continue to support this idea of perioperative immunotherapy. So, a lot of good stuff now and a lot of good stuff to come.
There were so many things at ASCO this year that were potentially practice changing and really exciting. I think that there were multiple drugs that were presented in early phases of development that look really potentially beneficial and appear to have relatively low side effect burden that are quite exciting. But one of the studies that really was a notable one was the Amplitude trial that included patients with HRR mutations in the metastatic hormone sensitive prostate cancer setting. And for those patients who received niraparib and abiraterone, they seemed to have an improved radiographic progression-free survival versus patients receiving just abiraterone. Of course, everyone getting ADT as the backbone there. And with that RPFS prolongation, we saw that this may be an opportunity to treat this particularly poor prognosis population with something that can meaningfully shift the disease trajectory. So I'm hopeful to see further data that will update us over time, as well as to see what happens with the regulatory review process, because this patient population certainly needs more attention and needs options. And if this one is going to help them, maintain that disease control and potentially even live longer on further data cuts, I think it will be important.
Most potentially practice changing in the future is the role of MRD testing using the phase-seq assay. We saw a large population-based analysis of prospectively collected data in diffuse large B-cell lymphoma, looking at the prognostic value of phase-seq at the end of treatment for diffuse large B-cell lymphoma. And what that assay showed is that patients who were MRD undetectable on the phase-seq assay had an extremely high likelihood of cure, a very low likelihood of relapse. Whereas those patients who remained MRD detectable at the end of treatment had an extraordinarily high likelihood of progressing within the subsequent 6 months. And so those patients represent an extremely high-risk population for relapse, and ultimately are a population we should be targeting before they manifest with obvious disease on imaging. And the phase-seq assay proved more prognostic and more powerful at predicting prognosis than baseline IPI scores or end-of-treatment PET-CT. And so I think that the phase-seq assay and MRD detection in general will add significant value to post-treatment imaging, and ultimately will hopefully prove a platform for treatment of MRD detectability as primary refractory disease with early incorporation of immunotherapies. And that's a question that's currently being addressed in prospective clinical trials. So while it's not practice changing today, I think it does represent the future.
Yeah, I think ASCO 2025 was really exciting for breast. We had quite a few big presentations. One of the themes, as I like to call it, is moving on up or moving some of these antibody drug conjugates into earlier line. This was the theme of Destiny Breast 09, looking at trastuzumab deruxtecan now in first line HER2 positive metastatic breast cancer instead of our DB03 approval in second line. And this showed a benefit in PFS of over 13 months. We also saw similar data of moving on up for sacituzumab govitecan. This was in first-line triple-negative breast cancer for those subset of patients that are PD-L1 positive and was in combination with pembrolizumab. We also saw a significant increase in progression-free survival with sacituzumab pembro compared to chemo pembro. And then the other notable abstract in breast really is Serena-6, probably a little more highly controversial. It was really a proof of principle for us that we can use something like the emergence of resistance mechanism, ESR1, to potentially change treatment. But how we're really going to incorporate in that practice remains to be determined. PFS2 is really important here. So saying, of course, we use another line of therapy, but are we really benefiting these patients over the long term in terms of them living longer or not developing pain or liver mets or something that's going to make their quality of life better? And that data in Serena-6 is still a little bit immature.
Which is it's a CSF1 receptor inhibitor, and it showed promising results in a phase 3 trial for something called tenosynovial giant cell tumor. It's a relatively rare tumor, but it can cause significant morbidity in patients. And it was promising because the response rates were over 50%. It was well tolerated. There's a treatment that's currently available, but the original treatment that was available is it sort of has some hepatic toxicity associated with it. There was another drug that was recently approved in that space, but it offers patients additional treatment options. And so that was encouraging. There was really this shift toward tyrosine kinase inhibitors in combination, either alone or in combination with chemotherapy, which looked promising. And so oftentimes we're thinking about with sarcoma treatments, many cases it's looking at a single agent therapy using a single type of treatment. We don't have as many combination therapies. And so there was a study that came out of Asia. It was a phase 3 trial that looked promising with a combination of a tyrosine kinase inhibitor and lotinib in combination with a drug called epirubicin. And this is sort of it's a drug that isn't available in the States, but I think it's a good reminder that sometimes these combinations can be beneficial. But it looked very promising. This was actually in a first-line setting. It showed an overall PFS benefit. It was too early to see an overall survival benefit, but it had good disease control. And so it was promising to see because many of our trials were trying to move away from treating sarcoma as a category and looking at more individual subtypes of sarcomas, since they are individual diseases. And we've had recent trials where we tried to look at an approach for sarcoma in general, and those have failed in phase 3. So it was interesting to see, and I would argue that that might suggest that this approach is potentially beneficial, because otherwise we had a really large group of different diverse sarcomas. We might have lost that benefit, which is what we've seen in some other studies where phase 2 trials were positive, but not phase 3. And then that same drug anlotinib was used for patients with late stage leiomyosarcoma, which is another type of sarcoma that we don't have a lot of treatment options for. And it also showed a very favorable PFS benefit.